My name is Michael Betel, and I'm the president and founder of the Fatty Liver Alliance. I'm here today with the Canadian NASH Network Leadership Team, also known as CanNASH, and they're here today to share their favorite abstracts and takeaways from the 2021 AASLD TMLdX conference. With me today, I have Dr. Mark Swain, professor of medicine and head of the Division of Gastroenterology and Hepatology at the University of Calgary, Alberta. Dr. Giada Sebastiani, associate professor, Department of Medicine at McGill University of Montreal, Quebec, and Dr. Alnoor Ramji, clinical associate professor, St. Paul's Hospital in Vancouver, BC, and Dr. Keyur Patel, associate professor of medicine at the Department of Medicine, Division of Gastroenterology at the University of Toronto. So welcome, everybody. It was a busy conference, although it was digital, but lots to talk about. So I'm just anxious to hear what you guys wanted to share as far as the most interesting abstracts. I don't know, Giada, do you want to start? Because I know that you were prepared.
Yes, sure. Hi, Michael. It's very nice to be with you, of course, and with all my estimate colleagues of CanNASH. So indeed, the meeting has been very intense, and there has been a lot of presentations and posters on NAFLD with dedicated sessions, many dedicated sessions. So I think some of the abstracts that I really enjoyed were related to some simple interventions. For example, I enjoyed the NASH FIT trial, which is a NASH FIT intervention in thrombosis. So basically, NAFLD patients are at high risk for coagulative events for thrombosis. And in this study, a randomized control trial, actually exercise reduced the incidence of events, but and most of all, it reduces actually the level of some coagulative factors. So it means that exercise benefits go even beyond cardiovascular outcomes or the weight loss. Another study that I really enjoyed was one presented by Professor Sanyal about liquid biopsy, which I think may be some part of the future in terms of non-invasive diagnostic of NASH. And indeed, with this liquid biopsy, it is based basically on protease activity in NASH patients versus healthy controls. Dr. Sanyal was able to show an area under the curve, so an accuracy overall of 0.97, which is really fantastic to differentiate NASH between NASH patients and healthy subjects. So I think this was also excellent. And finally, another abstract that I really enjoyed was the prediction of longitudinal outcomes by MR elastography, which has not been studied a lot in terms of prediction of outcomes. And in a study from Japan, they found that MR elastography indeed predict outcomes, liver-related and also cardiovascular if adjusted by the cirrhotic state. So I think these are my very nice takeaway that I got from the Congress. And I also would like to ask the other members of the CanNASH about indeed the interventional studies, because I think I found that there were several data on negative results for phase 2 trials for NASH antifibrotic molecules like Tandem, Topline, and Falcon. And I wonder if it's based not just on the molecular activity, but also on the design of the trials. Maybe they are too short, 24 weeks, or the endpoints that we are used are the really appropriate ones. So I launched the ball to the other colleagues and to my estimate colleagues of the CanNASH. Thank you, Michael.
Well, does anybody have any comments?
Yeah, I can see Alnoor is chomping at the bit there.
Right. Am I right? I mean, it's been interesting with regards to signals, right? I mean, it's been this plethora of clinical trials have not achieved primary endpoints for the most part, and sometimes they do achieve a histological improvement, particularly in the inflammatory component of steatosis and not so much in the fibrotic. And I think, Giada, it's to your point that, you know, are we looking at too short a study period for some of these fibrotic endpoints? Is it even reasonable to do this? And then we're also using a lot of surrogate outcomes, at least we have in the early phase studies, you know, MR-PDFF and MRE, and then you shift to liver biopsy, and there's this discordance between liver biopsies as well. So we're looking at a heterogeneous disease, we're looking at heterogeneous outcomes and a fairly short time span. So I think when you put all this together, it becomes more challenging. And, even when we looked at some of the longer phase 3 studies, there are benefits in certain small pockets and cohorts. And I think it's teasing these populations, which will actually improve based on these new molecules, what we need to do. That's really the next stage. How do we find this specific?
And that actually hits on, I think that's a key point actually, is this, this concept of heterogeneity. I mean, it was always just clumped. It was NAFLD, NASH, or spectrum and F1, F3, or whatever. But I was quite impressed at the meeting, which I thought was phenomenal from a NAFLD point of view. It's interesting how things have shifted towards NAFLD so dramatically, and there was just so many sessions on NAFLD. But the whole thing about these differences in individual patients, which is lost in these studies, which is it happens in other things like IBD and different diseases, and even in some of the PSC studies that have been done, you can see there's some patients that seem to respond and others don't, but they get lost because it's not an overall thing. And so I think the concept of a more personalized approach to NAFLD and NASH, and understanding the differences that make it so heterogeneous, and understanding how it's a metabolically driven disease that we really have to be addressing it, where it just struck me time after time that came out. And I think these trials reflect that. And we probably have to step back and kind of think about what we're looking at, how we're dividing the patients, and how we recruit patients, and then how we enter them into studies, and then what the endpoints are, because I think we're probably losing signals by clumping everyone together. What does everyone else feel about that?
Yeah, and I think you're absolutely right, Mark. One of the difficulties is, like take something like Tandem, which Giada just mentioned, Senocriviroc, intuitively that the mechanism of that, one of the compounds in that, the other one's an FXR agonist. Intuitively, the chemokine receptor agonist, should have an anti-inflammatory effect, but in the early phase studies, it showed an anti-fibrotic, so they moved ahead with it, clearly it didn't meet its primary. It was a safety study, of course, but it didn't meet its the targeted endpoints compared to the single agents. And we were all excited about combining therapy. At that time, there was another study from Gilead as well, which combined therapies, but again, in a difficult population, F3, 4. So I think you need longer duration. To your point, the population's heterogeneous. And what strikes me is a continued high response of the placebo groups in these studies. And I think, we need to kind of grab all their data and their samples and really look at it closely. Why is this group, why are they different from the standard of care patients for CU? Is it because they're seeing once a month? Is it something else? So I think we need to study those placebo responses in greater detail. And I was struck by that Japanese study as well, from Tamaki, with the MRE, with over a short period follow-up over 2 years, where they showed certain tertiles or quartiles of MRE. They'd split their stiffness values into were associated with outcomes such as HCC, but not cardiovascular outcomes, oddly enough. But really decompensation and HCC, right? It was very interesting. But when I quickly looked at their demographics, and one of the things which may come up as they try to publish it is their past history. 13% of them had a past history of HCC, so I wasn't sure, and a smaller percentage had past history of decomp. So it wasn't a truly clean population where you do an MRE and then you follow them prospectively. But clearly, this is the way we're going, in terms of combining markers and imaging elastography to predict clinical outcomes, which is ultimately what regulatory authorities want for your compound. Now we just have to show that improvements in these non-invasive parameters equate to improved outcomes. But we're on our way, as Mark says. We've seen a big change over the last 5 years in terms of the knowledge gap we're addressing, in terms of all the missing information we all wished for. It's coming through slowly.
And I thought there was a very interesting, this whole technology thing, and there was a lot. It wasn't so much in posters, but it was in some of the sessions and in the course itself, about these single cell and topographical transcriptomics and proteomics, which are essentially looking at a whole biopsy or looking at the cells that are within that person's liver and actually showing, well, the cells are really so diverse and so heterogeneous, and there's all these cell types that change what they do dynamically over time. And I think so as we get more information about not just the cells themselves and how they change and how they influence disease, but also where they are in the liver. Like if there even the zonal changes across the liver from where the blood comes in to where it goes out, there are big differences, and those change as the disease progresses and you get more fibrosis. And so I think we're just poised on the edge of an explosion of information, like Keyur was saying, that is. I think 3 years from now, we're going to understand this difference very differently than we are looking at it now, and that's going to drive a lot of the stuff when it comes to therapeutics, approach to patients, personalized medicine, all of that kind of stuff. And it might tie into liquid biopsy too.
Yeah, the multi-omics layering is very, very exciting, and we have the computational tools and biological plausibility because everything is made in the liver, so you can equate any of these things to the liver quite easily. But it is fascinating, actually. I totally agree. Yeah.
I have also another comment to discuss with the gentleman, actually, and which I find that the discussion is fantastic on the topic on invasive tools and also on therapeutics. And I was also struck by a work presented by Professor Bosch on the weight reduction and impact on outcomes from the simtuzumab and selosentib trials, because it looks like that in cirrhotic patients, actually, weight loss may not be as beneficial as initially thought. So I was wondering if you think it may be due to sarcopenia, which is something that is coming out as a big also biomarker in NASH, or frailty, or I was very interested in your opinion about this data.
Well, do you think part of it's too that as people get more advanced in cirrhosis, they mobilize a lot, their fat disappears, right? So the driver of their disease changes. So it might not be that you're, by doing what we think we would do with people that are non-cirrhotic, that have obesity or whatever, where they have a lot of fat in their liver. Once you start to lose that, maybe you lose the beneficial effect of exercise and things like that, and weight loss that you might see otherwise.
Yeah, I mean, I think that's the heterogeneity in all this. They looked at greater than 5% weight loss, right? And they saw, well, look, it really doesn't improve fibrosis in your placebo cohorts. And maybe it's connected to that point, the liver is replaced by fibrosis. It's no longer adipose tissue. You don't have that necroinflammatory component that you have in earlier stages.
Yes, I was struck by the fact that it was associated with liver-related outcomes. That it was, not just it was not associated with changes of fibrosis, but with outcomes. And since this was a bit concerning for me because still there are several data showing that exercise do improve, like portal hypertension, for example, in patients with cirrhosis. But what about if at least in some of them, we get actually overall worse liver-related outcomes? Is it that we have to adjust for sarcopenia, which I think an important biomarker? So I was really very interested in your opinion overall about this data as well.
Yeah, no, that's the key. I think, we all hesitate recommending dietary caloric restriction in our cirrhotic patients, right? They become malnourished very easily. And, even an overnight fast in a cirrhotic patient, it's like a non-cirrhotic patient fasting for 3 days in terms of the effects on their nutritional balance. You've got to be very, very careful, right? So, and on the same lines, actually, you folks probably saw the presentation by Dr. Ramiro Gomez, one of our dear friends and colleagues in Spain, with the Mediterranean versus low-fat diet. What do you make of that? So it was like 66 obese patients who were randomized to a low-fat 1,500 kilocalorie diet, or a Mediterranean diet, which Giada is very familiar with, over 3 months. And they had a pretty good compliance, up to 65-68% compliance with the diet. And they looked at, these are patients who had steatohepatitis and fibrosis in half to 2/3 of patients. And they found that basically both diets lost weight, about 3 to 4 kilograms over the 3 months. And they had benefits, knock-on benefits in terms of improving serum markers, AST, GGT, cholesterols, and also some of the surrogate markers for steatosis, steatohepatitis, and fibrosis. And the FibroScan values actually declined from 13 to 14 down to 8 range with a low-fat diet, and a little bit less of a drop, but for the Mediterranean diet. So there are some benefits and improvements in liver stiffness for sure, with just a 3-month calorie-restricted Mediterranean or low-fat diet, but no difference between the diets as such. What do you make of that?
I think it's very interesting, Keyur, because this data from Romero Gomez, and also I was listening to another presentation where they also investigated for the keto diet.
Mm-hmm.
So I think it's maybe we don't have enough data yet to really do a strong recommendation of one diet after, with respect to another, because as you said, in this trial of Romero, so a Mediterranean diet and low caloric diet, there was not actually really a significant advantage of the Mediterranean diet. I personally think that all this dietary intervention, they have also to be put in context, of the cultural context of the country and so on, because of course I eat Mediterranean diet and I'm very happy of all the results that are excellent for the Mediterranean diet, but many patients ask me and you for sure about the keto diet, intermittent fast diet, low caloric diet, and so on. So I think we need more and more, maybe comparative study, but always with a little bit of elasticity, as you said also very well, Keyur, on the, not maybe strongly prefer one or the other, as long as, of course, we have some effects. I'm interested in knowing what the other gentlemen think about this.
So, I mean, the common theme has obviously been weight loss, right? I mean, that is the common theme within them. And I think, like you say, you want to put a diet that is reasonable within a cultural context and also not being too aggressive. So I always tell patients, you want to be a moderate person. Extremism in anything is never good. And I think this would go to the same. And remember, these are short-term trials. You don't know long-term consequences by any means, which is always interesting. And then it goes back by how you are actually evaluating them. We looked at transit elastography, look at biomarkers, which we know are not the best. And an improvement in that means no difference in real fibrosis with that context of inflammatory and steatosis, which it portrays. So it becomes challenging when you're saying do this for the rest of your life, because I think that's a very strong statement, and the moderation context is important, and looking at these non-invasive markers.
Alnoor, if you go one step above just the diet and weight loss, doesn't it come down to the reduction in sugar and fructose? Isn't that one of the key contributors?
That's a key point. I mean, we've talked about it, right? Really, it's the fructose component of everything. So, using the low carb context, the low sugar context, and really pushing the green vegetable lean meats. And a lot of them have these commonalities. Intermittent fasting is, of course, a bit different than any of these, but the commonalities are within there. And then the exercise. We really don't have this context of exercise put into any of these diets, but I mean, it's a lifestyle. It's interesting how many patients will say, can I get something to treat this? And we talk about a behavioral change. That is difficult. It's very hard to change someone's behavior. No. To change somebody to take an extra pill or a shot a day or a month or whatever, that's not so challenging. People more can accept that, but to spend the time and energy in the behavior change.
Yeah, everyone wants a quick solution. Everyone's, I mean, and the next generation's even worse. They want, no one's got the time to put into the lifestyle interventions, to benefit something which you can't feel or see necessarily, right? So that's a difficulty.
And what often strikes me in the NAFLD clinics is that patients, especially if obesity is the driver, they say, look, I need knee replacements. I can't even walk, right? Mm-hmm. And so often it's very challenging them to talk about exercise at all, right? So it becomes a self-fulfilling prophecy, the circular thing. And they get depressed because they can't get out, and so they eat more, and they often pick the wrong foods, and so it's a really challenging. And this is where multidisciplinary approaches come in, right? We need to, really understand each individual's drivers. And
the behavioral support is becoming more apparent, right?
Yeah. And like look at Noom, right? I mean, these type of app programs that are cognitive behavioral therapy, really, it's about reassessing how you approach it.
Yeah, and we touched on
they can be quite successful, right? But,
Yeah.
you know.
For example, Michael, because what Mark and the other gentlemen were saying about and Alnoor about the diet composition from another takeaway, which is very important. I mean, as a pathologist, we all know, but I think for patients is very important, is that from the meeting, it was very much stressed the deleterious effect of the processed food, you know, any processed food. There was a wonderful lecture about that. So this is something that has to change. Really, the education has to change. Educational campaigns should be made. And I was very struck by the fact that in one of these presentations, processed food are started to be eaten very early in the life of children even, you know. And those who eat all this processed food since children, they are at much higher risk of having NAFLD and NASH in their adult age. So I think some policy has to be made to promote education against this deleterious kind of food, if the gentlemen agree, you know.
So I was going to take one moment on that piece. There was a beautiful PEAT study which looked at weight reduction and the non-invasive improvement in a very short period of time, and it just goes to show, you know, across all age groups, and potentially if we actually can do this early in life, before we have this significant necroinflammatory aspect, before we have fibrosis, it may actually change the natural history of this disease. And at the same time, like Giada says, you don't be restrictive in life, but you want to give guidance probably of how to do things well. And it really should start very early before all these things are set in place.
And which ties into the whole thing about the microbiome as well, because we know that diet is so influential on the microbiome. And there's a lot of stuff about the microbiome, this whole sort of gut liver axis as a driver of worsening NASH and worsening fibrosis. And I think as we get to understand that better, the influence of diet, the influence of supplements like a probiotic or a different type of diet, higher fiber, things like that, that where we can change the microbiome in a way that becomes beneficial to the liver. I think that area is really growing, and in the next few years we're going to really understand that in a better way, hopefully, and that I think will also help us understand why some patients do well, some people can't lose it. There's always people say, you know, I really can't lose weight, and do they have a microbiome that generates more calories out of a given diet than someone else? And you know, there's a lot of interest in these kinds of things, and can that be changed in a way that beneficially impacts their liver and the metabolic dysfunction that they have in their bodies.
Before we wrap up, I did want to ask one point about food inequality, inequity, right? That I don't know if they talked about it at all at the conference, but we can all suggest, like Giada, you were talking about, better food, not processed food, but there are people who can't afford to eat that way. And so we do have to take that into consideration too, I think.
Totally. That's part of the policy, government policies, right?
Absolutely. I think we should, with the policy, we should the prices of the healthy food should be reduced, while the price of the processed food will compensate and will be increased, I think.
It also ties into things like people talk about like when I mentioned the new map, or these type of apps, is the problem is they often cost money, and so if you're trying to go down that route and you don't have the money, you're struggling to feed your family, you're not going to be buying an app and paying an app for weight loss.
The other thing is there's a very powerful food lobby group. The people who make these processed foods are very, very powerful and very rich. So they want us to be addicted to sugar and salt, as I tell all our patients, and our job is to try and fight back at a young age and look at all the healthy initiatives at school dinners and things which Michelle Obama had started, and even before her, and it's got pushed back immensely, even in very liberal parts of the US. So it's a big battle, political, as we mentioned.
That's great. Thank you for those comments. And I want to thank all of you. I appreciate it. We're out of time because I know everybody has to go back to their clinics. And so I want to say thank you. I look forward to doing this again. We'll find another great topic, and appreciate it greatly.
Thanks.
Thanks for giving us the opportunity. Really good. It's always great to chat to everyone. Great to see you. Yeah.
Good chat anytime, right?
Take care. Bye-bye.
Bye-bye. Bye-bye.